Welcome to PGOG, Pathways to Growth in Obstetrics and Gynecology for Postgraduates and Consultants. Today's topic is infertility, the initial assessment and diagnosis of anovulation. Certain terminologies and important concepts which are commonly used in the management are infertility definition is inability to conceive with, unprotected regular coitus of greater than 1 year. Now, these two terminologies, fecundability and cycle fecundity, are important in the sense that whenever we counsel a woman, we need to tell of a infertility, we need to tell that even for a normal woman, probability of conceiving in a given cycle is only 20 to 30%, which depends on age. With advancing age, even there is further reduction in this fecundability. That means whenever we are giving treatment, we need to counsel a couple for their having a this relativity with the normal also. That normal also, it is not 100% in a given cycle. Only 20 to 30% is the probability of conceiving in a given cycle for normal women. Whereas with treatment also, then we have to compare with this only. Fecundity is probability of having live birth in a cycle, which is also around 20%. As we all know, main factors for infertility, we can have male infertility in 30 to male factor infertility in 30 to 40%, ovarian in 20 to 40%, tubal and peritoneal in 30 to 40%, and there can be combination in many couples with infertility. But in spite of doing extensive investigations, we can't find out a cause. Then unexplained is a group which is responsible for 10% of cases of infertility. This is a emerging concept in modern gynecology that cost effective management is preferred over finding a specific cause. This is important concept which is emerging rather than going for extensive investigations and pinpointing the specific cause. Sometimes it is better to initiate cost effective management options. Now, should we always wait for 1 year to initiate evaluation of an infertile couple? If you get a case of infertility as a long case in practical examination, or even if sometimes we are sitting in OPD and sometimes women do approach us as gynecologists and are asking that when should they be uh, going for evaluation or investigations or to find out what is the cause for infertility, whether it is always necessary by definition to wait for 1 year. There are certain indications for early evaluation, which the most important is whenever the age of a woman is greater than 35 years, then we can initiate the evaluation at the end of 6 months. Whereas whenever the age is more than 40 years, immediately we can initiate the evaluation rather than waiting for 6 months also. A woman having irregular or infrequent cycles, then in that case also we don't wait for 1 year. There is a previous history of pelvic surgery, pelvic infections, endometriosis, history suggestive of endometriosis. In these cases also, post marriage, there is no need to wait for 1 year. We can initiate the evaluation earlier at after 6 months. And if there is already a history of male partner with poor semen quality, then also we can initiate the evaluation earlier. So these are the four indications for early evaluation, which I think we should all practice also whenever we are considering when to initiate the evaluation for infertility. How will you start evaluation of an infertile woman? That if that history is that question is asked to you in examination, how will you evaluate? What will be the first step in the evaluation? So first step is history and examination. That we should always remember, that you directly don't never jump to the investigations. Always remember that so many clues we get in history and general examination, which are deciding in which direction we should evaluate further, or we should focus on which investigations. So that is the reason why history and examination is the first step. Obstetric history, menstrual history, coital history, past medical and surgical history, and previous treatment of infertility. If patient, so many times we are getting patients who are coming to us and there is a they have a large file which has many papers in that, and so many times so many investigations are repeated from one hospital to the other. Patients are changing the hospitals frequently with infertility, with a thought that maybe change of the hospital can bring success or can provide them with a pregnancy. So these are that leads to repetition of the same investigation sometimes, unfortunately. So we need to go through that long list of investigations and long list of papers evaluation, so that we do get a important clues about the cause of infertility. General examination, we have to see whether patient has obesity, go for BMI, whether there are features of hirsutism, excessive hair growth on face or extremities, thyroid swelling, breast secretions. That is very important. I still remember a case when I was in my early days in as a gynecologist in the career. There was a patient who approached to our hospital, and since last almost 8 to 10 years, she was going from one hospital to the other, and she was being treated, investigated, and what she had was infrequent cycles. Never she was examined for the presence or absence of breast secretions, and she had breast secretions. She had significant hyperprolactinemia. Even her, she had pituitary macroadenoma. When we did her imaging, CNS imaging, she had a pituitary macroadenoma, and you won't believe that the month when there was a surgically, it was removed, this pituitary adenoma, next cycle she conceived. So that is how the main aim of telling you this, uh, my own experience is for the stress for the examination. Simple examination can give us so many clues, and if we miss that, unfortunately, patients are just being given some drugs for the um, in this induction of ovulation, or some over-the-counter drugs are also sometimes given, or patients are just going from one hospital to the other with this unfortunate outcome like this. I hope that now in current practice, this experience you will not be, I hope that you will not be facing the same scenario. But that was long back, around 25 years ago, when it was not that much of awareness about hyperprolactinemia was also not there in the gynecologist also. Or abdominally, to see whether there is any tenderness or mass. Per speculum examination, to see whether there is any infection, cervical infection, cervicitis, vaginal infection. Per vaginally, to see the size of uterus, position of uterus, and whether there is any tenderness. And also we have to see for a fornage in the pouch of Douglas, whether there is any nodularity, which will be suggestive of mainly endometriosis if it is a tender nodularity, and in the fornaces whether there is any mass or tenderness. So that will be on general and on the per abdominal and per speculum and per vaginal examination. Now, how history and examination helps to decide further evaluation? What clues we are getting? If that question is asked, your answer should be um, irregular and infrequent cycles. We should evaluate the patient along the lines of to know whether there is any ovulatory dysfunction. We should then try to see whether this patient is a regular ovulator, or whether she is irregular ovulator or absolutely anovulatory infertility is present. For that, we need to investigate or evaluate the patient. New onset abnormal uterine bleeding, then whether there is any uterine pathology is there, such as there can be a leiomyoma or adenomyosis can be there, with more and more girls opting for pregnancy in with age already going beyond 30 or 35 years. We are getting these pathologies more commonly affecting the fertility. If there is a history suggestive of pelvic inflammatory disease, abdominal surgery is there, previous abdominal surgery or previous ectopic pregnancy, then we need to focus on to see whether there is a tubal pathology or not. Recent onset or worsening dysmenorrhea, dyspareunia, tenderness in the fornicial tenderness over the uterus, or tender nodules in pouch of Douglas, we need to then focus on mainly evaluating for endometriosis. Now, what initial non-invasive test you will perform in an infertile couple? Whenever a patient comes, what will be the initially we go for non-invasive, and if non-invasive are not giving adequate information, then only we shift to the invasive investigations. So initial evaluation, test for ovulation, especially if there is a menstrual history which is suggestive of ovulatory dysfunction. Semen analysis should always be done as initial evaluation before doing any invasive evaluation in the female partner. And test for ovarian reserve to be done only in indicated women. So, should a testing for ovarian reserve be done universally in all infertile women? If you are asked whether every case of infertility you will do the testing for ovarian reserve, your answer should be no. Universal testing is not recommended, as it is not going to give us useful information if it is done in universally in all women having infertility. Indications to test for ovarian reserve are elderly women age greater than 35 years, unexplained infertility, history of ovarian surgery, chemotherapy or radiotherapy, chemotherapy or pelvic radiotherapy. Patient, if woman is a smoker, if there is a family history of early menopause, then we can go for test for ovarian reserve even in a woman less than 35 years. And if there is no response to gonadotrophin stimulation for induction of ovulation, then we can go for test for ovarian reserve. So these are the specific indications, and universal testing for ovarian reserve is not indicated, and usually we go for ovarian reserve testing as anti-Mullerian hormone, antral follicular count, or FSH testing. I have already, uh, in detail, I have already discussed this test for ovarian reserve in a separate video, and it is requested that uh, you should all go through that video so that there are indications and how to interpret the test for ovarian reserve. What are the tests? You are likely to get a short answer question SAQ also on ovarian reserve for students, and that is why I recommend you to go through that video once. Now, what are the various tests used to diagnose ovulation if that question is asked, or if you are asked what are the tests done to assess response to ovulation stimulation? That means we are treating a patient of anovulation, and during treatment also we need to see the response to our treatment, response to ovulation stimulation. So same investigations are done to diagnose ovulation or to identify an ovulation. Same tests are done to see the response to ovulation stimulation. So various tests are menstrual history, basal body temperature, serum progesterone, urinary LH excretion testing, endometrial biopsy, transvaginal ultrasonography. This is the list. That doesn't mean that in every case we will be doing. There are certain indications to select certain test to detect the ovulation or to assess response to ovulation stimulation. Now, how menstrual history helps us to assess ovulation? Features suggestive of an ovulation will be irregular cycles. The definition of irregular cycles we have already seen, as it has been given by Palmcoin classification system. One, that irregular cycles are when the difference between the longest cycle and the shortest cycle is greater than or equal to 8 days. That then we call a cycle as irregular. So presence of irregular cycles with unpredictable flow, that means sometimes the blood flow is more, sometimes it is less. That is also goes in favor of anovulation. Infrequent cycles, now remember these two terminologies are not same. Irregularity is difference between the cycles is greater than or equal to 8 days. Infrequent is long cycles where the interval is greater than 38 days. These definitions should be at the tip of the tongue for all the students. Whenever you say irregular, you will be asked what do you mean by that. If you say infrequent cycles, you will be asked the definition of infrequent cycles. Cycles are unpredictable. That is true, especially for women. Now remember that an ovulation is sometimes all the cycles a woman can have as ovulatory, all the cycles a woman can have as anovulatory, or there are certain women who are irregular ovulators. So in these women, the cycles are unpredictable. Sometimes the cycle is as expected, regular, or not infrequent, but sometimes what is happening is it then shifts to irregularity or infrequency. So then the history will be unpredictable cycles in irregular ovulators, especially. Absence of spasmodic dysmenorrhea, ovulation mid-cycle pain, which we call it as Mittelschmerz, absence of premenstrual breast discomfort, mood changes, or heaviness, all these are suggestive of anovulation. Now, strong and consistent history suggestive of anovulation does not need confirmation by other tests. This is most important concept I want all of you to remember in practice also. When there is a classic history, consistently patient is giving such type of history, then there is no need to go for any invasive or expensive investigations. Directly one can, it is an indication to search and test for cause of anovulation. That means strong menstrual history, consistent menstrual history, that is itself is sufficient to consider the woman as having anovulatory infertility. In that case, what is the next step which is recommended is we can start evaluating a woman to see for cause of anovulation rather than doing investigations to confirm our diagnosis. Strong menstrual history itself is sufficient for diagnosis of anovulation, is given in by even guidelines also. If you see the reproductive guidelines, even WHO guideline is there, or UK guideline or American guideline, all guidelines are suggesting the same, that when it is a consistent history, classical history suggestive of anovulation, there is no need to do further testing for confirmation of anovulatory infertility. Regular cycles almost always are ovulatory, though few rarely there are women where regular cycles, in spite of regular cycles, there can be anovulation. Now, what is the place of this basal body temperature to assess ovulation in present day gynecology? If you are asked this question, advantages of basal body temperature are it is cheap, non-invasive, easy to do. It can be done at home. There is no need of going for repeated hospital visits, and it is in woman's hand. Disadvantages because of which this BBT is not a method of choice, or it has been replaced by the better investigations now in the current present day gynecology. The reasons are it gives ovulatory diagnosis in retrospect. It cannot define or identify the timing of ovulation. It cannot be used to assess fertile period. Now, what is fertile period is also called as fertile window, which is usually considered as 5 days before the ovulation takes place, and including the day of ovulation, we can say it is a 7-day window, because life of release ovum is only for 12 to 24 hours. The ovum can get fertilized after the ovulation for next 12 to 25 4 hours only, whereas life of a sperm is 3 days, and it can be maximally it can be up to 5 days. Time taken for temperature rise after the ovulation itself is 4 to 5 days. So after ovulation takes place, after 4 to 5 days only, we come to know that there was ovulation. That is how it is not going to help us to assess the fertile period, or to plan the for planned intercourse, or even for insemination. Now, this is somewhat stressful for a woman with a daily reminder of her infertility. Whenever, for many months, if a woman is going for this BBT, it can sometimes be frustrating and it is tedious. And these are the reasons why this has been replaced by better tests which are now available. Now, BBT has got a place only in places where there is difficulty, rural areas especially, where there is a difficulty in going for lab investigations necessary for the diagnosis, or if whenever there is a problem even to go ahead with ultrasonography. What is happening with the basal body temperature? Oral temperature is taken as first thing in the morning, and you get a biphasic curve where, yeah, before ovulation the temperature is between 97 to 98 degrees Fahrenheit, and after the ovulation there is a rise by zero point 0.4 to zero point 0.8 degrees Fahrenheit. But this rise is seen around 4 to 5 days after the ovulation. That means around day 18 we will be getting the persistent rise, and that is the reason it has been replaced by better tests which are now available. Can serum progesterone be used to diagnose ovulatory cycles in a case of infertility? If you are asked what is your opinion? Do you think serum progesterone is a good test, or do you whether you will advise serum progesterone testing in a case where you want to assess the ovulatory function? Advantages of serum progesterone: it is a simple test and it is the most commonly used test. It is most popular of all the tests for ovulation. It gives objective evidence of presence of ovulation, as opposed to now this temperature assessment. We are relying more on a woman's way of going for that, and that sometimes there can be error also. But here it is a objective assessment. It is reliable provided it is appropriately timed. This is most important, that it has to be done one week before onset of menstruation. So correct day will be day 21 for 28-day cycle. But ovulatory cycles are not always coming regularly at 28 days. Sometimes ovulatory cycles, there is a range of 25 to 35 days. Or it is said that even from 21 to 35 days also, sometimes it can fluctuate the cycle frequency, even ovulatory cycles. And that is the reason this day 21 is not always a correct day to go for this serum progesterone. And if it is cycle is not 28, it is 35 days. So now here we can see here that if it is a 28-day cycle, then by day 21 there is a rise in the serum progesterone which is around 7 to 8 nanogram per ml. Anytime it is less than 3 nanogram per ml, it is suggestive of anovulation. Remember this is most important. Even unit is important. 3 less than 3 nanogram per ml serum progesterone, that is almost suggestive of anovulation provided it is appropriately timed. Now the catch here is, suppose a woman is going to have a 25-day cycle and you are doing it on day 21, already there is a fall which has started. So it will be falsely, it will be a low value, false positive it will be. On the other hand, a woman is having 35-day cycle, though it is ovulatory, and you are doing progesterone on day 21. Again, what will happen? Still, the rise has not initiated only day 21 in a 35-day cycle. And this is the reason that most important disadvantage is it is difficult to decide the appropriate time. This is the greatest disadvantage of this serum progesterone estimation, because ovulatory cycles are also not always every 28 days. There is a range from 25 to 35 days, and for 25-day cycle or 35-day cycle, you are doing 20 this serum is progesterone estimation on day 21. In both of these scenarios, the level will be low, and then you diagnose it as an ovulatory cycle as a false positive diagnosis. False low levels if taken on day 21. Test needs to be repeated if no menses after 7 days. This is important, that if after what is if it is a 28-day cycle, day 21 you do, then it is expected that after 7 days there should be initiation of menstruation. But if no menses after 7 days, that means it is not 28, it is longer, it might be 35 days or something like that. So you need to repeat the test in this scenario. Now this serum progesterone, as it is dependent on LH secretion, and even GnRH, you know that it is secreted in pulses from the hypothalamus. Same way, LH is also secreted in pulses. Similarly, this serum progesterone also, it is not remaining consistently raised. It is also secreted in pulses. So it is not an indicator of quality of corpus luteum as it is secreted in pulses with wide range in normal cycle. Suppose in a normal cycle also you do serum progesterone level, there will be so much of fluctuation. It can fluctuate right from 5 nanogram per ml to 40 nanogram per ml because it is being released by corpus luteum in pulses. And that is the reason serum progesterone estimation only helps us to diagnose whether it is ovulatory or anovulatory cycle provided it is appropriately timed, but it never it is not an indicator of quality of corpus luteum, or it is not going to help us to diagnose corpus luteal insufficiency or luteal phase defect, LPD. For that, this serum progesterone is of no use. That is important. If you are asked whether we can diagnose corpus luteal insufficiency by doing serum progesterone estimation, your answer should be no, because there is a wide range of fluctuation in a normal cycle also because of its way of release from corpus luteum, which is in pulses. Ups and downs are there normally also, and that is why this level is not going to help us to diagnose luteal phase defect or corpus luteal insufficiency. Now coming to the next is urinary LH excretion test. Whether this LH test provides accurate diagnosis of ovulatory cycles. What are LH or ovulation prediction kits? LH kits are home based as we do urine pregnancy test. Similarly, urine LH tests are also available, which are called as LH kits or ovulation prediction kits. This is the greatest advantage of LH over progesterone also. That if we do serum progesterone, still prediction is not there. That means the rise in progesterone will be there after the corpus luteum is formed, post this ovulation. That means day 21 we come to know that whether it was a ovulatory cycle, and it is progesterone is at all not absolutely not helping us to know the fertile period. But LH is giving us a prediction when ovulation will is likely to take place. So it is the test greatest advantage of this LH kits, ovulation prediction kits. That is why these are called as ovulation prediction, that it predicts ovulation in next 24 to 48 hours. Whenever LH kit shows positivity, next 24 to 48 hours is the time when the ovulation is likely to take place. It is reliable. 90% probability is there that it is giving us a correct information. It is easy to perform as it needs less time and effort. The most important is woman is not going to hospital or to a sonography clinic as opposed to serial ultrasonography. This LH testing is it is a home based testing, so that is why it is easy to for a woman to perform from suppose many months a woman is going to has to go for these tests. You are treating a woman even for with induction of ovulation. It is sometimes tiring and practically not possible for a woman to visit hospital so many days of a month, almost 8 to 10 days if we rely on ultrasonography, and that is how it is better. It is involving a woman in her assessment. It is useful for insemination or planned intercourse to improve the success. So it is most important advantage is it is giving us reliability is there, and it is providing us information about fertile period. Disadvantages: borderline results sometimes are confusing, and it is false positive in 7%. False positive is we have a positive LH test, but the cycle is still anovulatory. These are the cases where there is a luteinized unruptured follicle. As you know, what is happening in luteinized unruptured follicle is this is the follicle, and here what is happening is instead of this ovulation being taking place, ovum is remaining entrapped, but there is a luteinization. That means the follicular cells are getting converted into luteal cells. That is why there is a secretion of progesterone also, and that will show us a LH rise also. But there is a anovulation. Anovulation is, it is the condition which is called as luteinized unruptured follicle. So luteinized unruptured follicle is a most difficult, though it is rare, it is most difficult to diagnose, and we can't diagnose it by doing progesterone testing or LH testing. The only way it can be diagnosed is by doing ultrasonography. So as we can see here, this daily evening testing is done. This LH testing is that it is said that by evening the possibility of having a positive test is more. It is done 2 to 3 days. It is start initiated 2 to 3 days before expected time of ovulation. So it needs to be, suppose you expect the ovulation to take place on day 14, then at least 3 days before that, 2 to 3 days before that. So around day 11, we have 11, 12, 13 like that. So we have to initiate 2 to 3 days before expected time of ovulation, depending on the previous menstrual history. Now this rise in the LH is it is very short lived. It is remaining only for 48 hours. 48 hours is the duration of this LH surge. So it is a very short lived, and that is the reason we have to keep on doing the testing on a daily basis. Once the test is positive, there is no need to repeat the test. And next, the day when the LH test is positive, with that, and next 24 to 48 hours, that is the maximum fertile period when we can advise a woman to go for planned intercourse, or insemination can be done during that period. So that is the advantage of this LH kit. Now, what is the place of endometrial biopsy? Whether you will do endometrial biopsy to diagnose ovulation or to diagnose luteal phase defect. Now, if you see the previous textbooks, there was so much of stress which was given on endometrial dating. Endometrial dating was a way was which was even given in the standard textbooks as a way of diagnosing luteal phase defect. So, if you are asked, what is your opinion? What is the present day status of endometrial biopsy to diagnose ovulation or luteal phase defect in a case of infertility? Now, endometrial biopsy is not done as a routine. Its disadvantages are more, and better tests are now available. That should be your answer. Disadvantages are, it is invasive, likely to even sometimes it is uncomfortable, likely to even introduce infection, or vigorously done can damage the endometrium also. It cannot provide fertile period. It cannot be repeated in multiple cycles. Multiple times you can't keep on doing the endometrial biopsy. It is too uncomfortable and invasive. It is not a reliable indicator of luteal phase defect, as endometrial dating is most unreliable is important concept. I want all the students as well as consultants to focus on that endometrial dating is outdated. It has been seen by shown by studies that there are so many inter observer and intra observer, variability is very high, and it is very subjective, and that is why it is not considered as a reliable indicator of luteal phase defect. Its advantages are, it can be done as OPD procedure under local or paracervical block or sedation. It is reliable provided it is again appropriately timed. It can most only main advantage I think in the present day or modern gynecology is it can diagnose endometrial hyperplasia or endometritis, especially tubercular endometritis. Sometimes is yeah, that is the only way it can be diagnosed beyond doubt. So it is only indicated in suspected endometrial hyperplasia. A woman who is having infrequent cycles of long duration or amenorrhea, and there is a thickened endometrial thickness is more than normal in a by ultrasonography. Such cases we need to do, or PCOS, long standing PCOS women, elderly women, These are the women where we should be going for endometrial biopsy to rule out endometrial hyperplasia. Rarely we can have a endometrial malignancy also, and to diagnose endometritis. These are that is the only indication. Otherwise, as a routine, endometrial biopsy should not be done because we have better non-invasive tests such as LH is better, ultrasonography is better, serum progesterone is better as compared to endometrial biopsy. Now, what is the place of transvaginal ultrasonography to assess ovulation? Transvaginal TVS sonography. Its advantages are it provides information about the number and size of follicles. So, especially whenever we are treating a woman of an ovulation, this is the best way to gain the information by transvaginal sonography. How many follicles are developing and what is the size of follicles. It provides most accurate assessment of timing of ovulation. As you all know, in a woman, whenever it is greater than 18 millimeters size of the mature follicle, we expect that ovulation will is likely to take place in next 1 to 2 days. So that is how it gives an accurate assessment of timing of ovulation. Rare luteinized unruptured luteinized follicle, which we have already seen in the previous slide, it can be diagnosed only by this transvaginal sonography. As compared to transabdominal, TVS gives better images and better reporting is also possible. Now, there are certain disadvantages of this sonography. It needs serial testing. As day 10, usually we need to initiate this assessment, and a woman has to come to the hospital and repeated hospital visits, which are not always practically possible for multiple cycles for a woman. It is expensive, invasive, and uncomfortable, especially transvaginal sonography. It is not always accurate. This is important as ruptured follicle can be refilled with the fluid. So it is not always a straightforward way of diagnosing ovulation. It can after rupture it can again get refilled with the fluid, or another growing follicle can look like a dominant follicle. Even if it has this follicle has ruptured, by this time this another follicle is now increasing in size. And next day you do sonography and what you see is that other follicle, and you say that there is no ovulation has not taken place. That is also likely scenario, and that is the reason why it is not always giving us 100% diagnosis of ovulation. So it is said, classically it is said that no test, single test is giving us a definite 100% result about the ovulation except pregnancy. It is not suitable or it is not necessary for the diagnosis of ovulation. It is too expensive, too invasive, needs repeated hospital visits, and that is why it is not necessary for the simple diagnosis of an ovulation, for which we have serum progesterone, serum or this LH kits, which are better. It is suitable to monitor whenever we are giving gonadotropins for induction of ovulation. For this indication, it is the choice of investigation. So this is how it looks before menstruation, immediately after the menstruation, before ovulation, imminent ovulation. This is the mature follicle, which has a well-defined margin. Then there is a collapse follicle with some echogenicity inside, and with increase in the fluid in pouch of Douglas is suggestive of ovulation. Now, how do you select an investigation for assessment of ovulation? We have seen so many uh, tests now. So, which test you will go for in a certain woman? Now, if we want to have advise the patient for a planned intercourse or insemination, and we want to know the fertile period, that is the main indication, then the best method will be to go for LH kit, because it is the ovulation predictor test. It gives us a clear indication that now next 24 to 48 hours there is a likelihood of ovulation being taking place. Ovulation confirmation, if we want to do, if menstrual history is not consistent, in that case properly timed, appropriately timed serum progesterone will be the our investigation of choice. Oligomenorrhea or menorrhea increase endometrial thickness. We are worried about whether there is a endometrial hyperplasia or malignancy. Then we go for endometrial biopsy. Amenorrhea and we want to rule out endometritis, tubercular endometritis. Then also we go for endometrial biopsy. Now we are using LH kit, but it is not of use, and we want to do insemination, but LH kit is not giving the proper results. These are the cases where we have to go for transvaginal sonography. Remember that. Otherwise, it is not the first choice of investigation. First choice is always LH kit, but LH kit is not giving reliable information. Then we have to rely on transvaginal sonography in women where we want to plan the insemination. Now, this place where no laboratory tests are available, ultrasonography is also not available. Remote areas, there we can proceed with the basal body temperature to get some idea about whether the cycles are ovulatory or anovulatory, which is the test which gives us a first suspicion about anovulation is menstrual history. Strong and consistent menstrual history, no further tests are required if it is consistent. If it is inconsistent, then only we go for this properly timed serum progesterone. Now, next is classification of causes of anovulation. Once we diagnose anovulation, our next aim is to know the cause of anovulation, because whatever is the underlying cause, we need to address the underlying cause. We need to take care of the underlying cause of anovulation. That will improve the success rate of our treatment for anovulatory infertility. For this, that the classification which is used for anovulation as a cause of infertility is WHO classification 1973. There are four groups. Group 1 is hypogonadotrophic hypogonadal anovulation, where both FSH and estradiol are low. FSH is either low or it is lower limit of normal. Usually here there is a hypothalamic cause, such as there is stress, physical, psychological stress, anorexia nervosa, Kalman syndrome, or excessive weight loss. All these, or even vigorous exercise also. Or in athletes, what we get is this WHO group 1 as a cause of anovulation, where there is a hypogonadotrophic hypogonadal anovulation. Change in the lifestyle itself can help. Or whenever, if we are suspecting a say CNS tumor, there is no such history of excessive uh, exercise, or some diet related to diet. Suppose there is no history suggestive of anorexia nervosa or other related disorders, then, or sudden weight loss is also not there, then we need to rule out a CNS tumor by doing a CNS imaging. WHO group 2 is normogonadotropic normoestrogenic anovulation, where FSH and estradiol are normal. LH might be raised, and the most common condition is polycystic ovarian syndrome as a cause of this group 2. Group 3 is hypergonadotrophic anovulation, where FSH is raised, AMH is reduced, and the most typical condition is we have in this group 3 is premature ovarian insufficiency, POI, where what we get is a raised FSH and fall in AMH. Group 4 is hyperprolactinemic anovulation. Prolactin, whenever is raised, there is a separate group for that. Raised prolactin is associated with fall or lower limit of normal of FSH and fall in estradiol. And then we have to see what is the cause of hyperprolactinemia, whether it is because of hypothyroidism, whether it is drug induced, patient is taking some drugs which are leading to hyperprolactinemia, or whether there is a presence of pituitary adenoma that needs to be ruled out. So this classification is important. I thought that I need to include it in this video only, because next video we are going to see the management of anovulation. So to understand the underlying groups, that helps us to mainly to see for this evaluation to decide what should be done. So here we have hypothalamus, pituitary, and ovary. Hypothalamus is releasing GnRH, pituitary mainly FSH, and it acts here, and there is a estradiol which is secreted. So we do this FSH and estradiol. Day 3 is the usual day when FSH and estradiol is done. Now if both are low, both, then it is group 1, WHO group 1, both are low. And here problem is here. Whenever both are reduced, then FSH is also lowered, estradiol is also lowered, problem is hypothalamic. Problem is here. That is what you remember, group 1, problem is at the hypothalamus. Group 2 is FSH and estradiol both are normal, and most common is PCOS. Group 3 is, here there is a problem at ovarian level. So what we have is mainly raised FSH in the group 3. Group 3 we have raised FSH and problem is here. So group 1 problem is at hypothalamic level. Group 2 is PCOS. Group 3 is problem is at ovarian level, whereas because the most common is premature ovarian insufficiency, where there will be raised FSH and fall in AMH. And special category is group 4, where what we have is a rise in prolactin level, raised prolactin. That is group 4. So that is how we, by doing even FSH, estradiol, prolactin, we do get this idea about what is the most likely cause of anovulation as group 1, group 2, group 3, and group 4. Now, how will you investigate a woman diagnosed with anovulation? In a case of infertility, investigations are to be directed to know the cause of anovulation, and most important, as we have seen in the previous slide, is day 3 serum FSH and estradiol level. If it is group 1, both will be reduced. And in these cases, if some lifestyle disorders are not there, mainly we have to focus on lifestyle disorders as hypothalamic. And if these are not there, we have to do the CNS imaging. Group 2 is where what we get is a normal. It's FSH and estradiol. So we suspect PCOS depending on the diagnosis. As we know, for PCOS, we have the diagnostic criteria. Hyperandrogenism is to be there. Along with that, if there is anovulation, we go for LH, which might be raised, testosterone level, and ultrasonography criteria to be seen. But main diagnosis, anovulation and hyperandrogenism is sufficient to diagnose it as a case of PCOS. Group 3 is mainly there is a raised FSH. So obviously problem is at ovarian level. And here we have to we suspect premature ovarian insufficiency, and we confirm it by doing AMH. Group 4 is mainly for prolactin, depends on prolactin, raised prolactin. To know the causes of hyperprolactinemia, we do TSH and we have to do CNS imaging, mainly if we are suspecting a pituitary adenoma. Thank you so much. Next class we'll see the treatment of anovulatory infertility. Mainly I have taken help of Spirops and Novak's gynecology, and I have gone through the guidelines for the evaluation of an infertile woman or infertile couple at the initial evaluation, as well as for the detection of ovulation. Thank you once again.